the best part of this session is our featured guest. So we have Dr. Lora Thompson, who's a clinical psychologist at the Moffitt Cancer Center, who will be giving us a talk about psychosocial factors that are involved in individuals, or that individuals with inherited cancer risk might face. And this is something Lora has been clinically working on for many years now. And then we have our other experts here, BRCA carriers. We have Marleah, Kruzel, who herself is a BRCA2 carrier, but also a communication and behavioral scientist at the University of South Florida. And we have Kathy Baker, who's a BRCA1 carrier, and also the founder and executive director of My Faulty Gene. And we'll be joined by panelists, as I mentioned already, Debbie Cragun, my close colleague across many different efforts, but Debbie is a genetic counselor as well as a PhD trained implementation scientist based at the University of South Florida, where she also leads the genetic counseling program. And then my other colleague and friend, Dr. Kelly Metcalfe, who is based in Toronto, at the University of Toronto, and is a senior scientist at Women's College Hospital as well. So with that, I'll go ahead and introduce Lora and just a few other details. She's the director of the Integrative Medicine Service at Moffitt, and she's focused on providing support, managing symptoms, and improving coping skills among cancer patients, including those with inherited cancer. So Lora, take it away, and thank you so much for being our guest expert.
Tuya. Yeah, so what you might wonder what integrative medicine is, right? So I work in behavioral and integrative. Integrative is our service that offers yoga and meditation, massage to some of our patients. So I consider myself a generalist, right? What that means is any and all cancers. It doesn't matter the diagnosis, the age. I see anyone that's referred to me in the clinic, and also with our genetics counseling service, we've got sort of an arrangement that they can refer folks to me that don't have a cancer diagnosis, but have a genetic predisposition. So I'll see a few of those folks as well. So I've been doing that for many years now. And sorry, there's a bit of a delay there. So before we talk about coping, I think it's just important to understand distress and kind of put that into a context, because, right, most people that end up to me are sent to me because there's some level of distress. No one sends a patient to me if they're perfectly happy and have no issues, although a few people might ask, to meet, but by and large, people are experiencing some form of an emotional reaction. So I've characterized here just sort of three possibilities, right? You've got your positives, your negatives, and your indeterminate. So generally, if we look at some of the literature historically that's been published in the area of genetic predisposition, and I'm not recalling specific studies in terms of how many had cancer and the genetic predisposition versus just were unaffected, but those that get a positive result, right, we tend to see immediate distress, elevated distress that subsides over time. But we see this sort of similar pattern in cancer diagnosis, and when there's a change in treatment, right, when whatever sort of new information happens, that's when distress increases, and then what we hope happens is it decreases over time. There's likely to be a subset of folks that have clinically significant distress, right? So these folks that have some sort of maladaptive response that's dysfunctional or interfering with their ability to function that we need to address. Now, I want to, again, qualify this, that this is dependent on the literature that we have, right? So if many of the studies have been done in BRCA, then we've got studies that are homogenous, right? A lot of women, because there's a smaller percentage of men. And then there's also studies that maybe have been more with Caucasian, higher SES. So we have to just be careful that maybe we don't necessarily have the full picture. It's dependent on the studies that have been published. Negatives results, right? There's going to be relief. Most people feel relieved, though some might experience that survivor's guilt. If their family member was positive and they're negative, why them and not me? And if on a rare, right, if we've had a situation where somebody's made decisions because they thought they were at risk, but now they find out they're negative, of this very rare, but for me at least, it could happen. And then the inconclusive I've find is more distressing for some of our patients than the other two, because it doesn't relieve the uncertainty that they might experience about the future because they aren't sure. So what are some risk factors, again, based on the what's been published? Younger age women, single, lower SES. There's been at least some studies with BRCA patients or affected individuals that if they had children, they were more distressed. There was a study with a Lynch syndrome population that individuals that were of Black, Indigenous, or people of color, that population might be more distressed. There could be disease-related factors. So I can imagine if you're diagnosed with cancer at the same time that you find out about the predisposition, current symptoms that you're experiencing, if you have other family members that are diagnosed with cancer. A lot of the psychosocial issues have to do with sort of perceptions, what your understanding of risk, how threatened you feel by this, what your experience has been with your family cancer. So some patients are caregivers or have had multiple family deaths. So they're, when they come to see me, they're recalling all of these experiences that their loved ones have, that are distressing or traumatic in some cases. If they have comorbid psychological conditions, there's at least some suggestion that potentially if they expect that they're going to have a negative result, but then they get a positive one, that they could be more distressed. Coping style, right? If you don't have good coping skills, it lends itself to more distress. Limited social support. And then there's some family. There's been at least a couple studies looking at sort of what order of testing, right? If you were the first tested or you had others that were positive, that you might be more distressed. There's some family qualities. If you have partners that are anxious, you don't have good communication or cohesion in the family, or you anticipate some negative results that, some impact on your relationships, or you feel guilty about passing that mutation on to children. So these could be some of the factors that are associated with greater distress. And, we've often, distress. I want to just bring up some of these issues. These are some key issues that I sort of see when people are experiencing increased distress, right? And I mentioned before about this threat appraisal. So this is kind of that perception of risk, and also I think health literacy has a lot to do with it, right? So people are not, I'm generalizing, but some people are not good with statistics and they don't understand what that risk means. And I even see this in individuals when they get a negative test result, or they're told, you don't have it. And they're like, I don't understand. I have these family members with it. So why don't I have this genetic predisposition? And I see the other lack of understanding is when I see patients coming in saying, I have nobody in my family with cancer, so why did I get it? So they think that the only way you can get it is to have this this genetic predisposition. So there can be some misunderstandings out there, and that can affect how people, their distress level as well. Coping appraisal. So what I mean by this is, how people perceive their ability to cope is going to make a difference in how they handle this kind of a situation. So self-efficacy, meaning, do they feel that they have the ability to cope with a positive result, an uncertain result. Or response efficacy, meaning do they think that the strategy they're going to use to cope with is actually an effective strategy? And then this idea of uncertainty, right? There's a lot of uncertainty in the future. Am I going to get cancer? Am I not going to get cancer? Is this the right decision that I'm making, right? Decision making, it can be a major part of what are, my patients that I've seen have been dealing with across all areas. Should they get testing? What kind of surveillance do they want to do? How can they communicate this information? What about fertility issues? What cancer treatment should they choose? Right. I mean, I see a lot of breast cancer in my clinic. Right. And so now we have, a lot of other treatments that they can give, these immunotherapies targeted, Verzenio, all these other types of things. And so people are being offered trials and they want to know, should I do that? And then privacy, people still feel sort of stigma and discrimination in some ways. And I'm trying to think of a couple examples, of patients I've seen recently that are faced with some of these issues. I had one patient who had to make a decision, right? So she was positive. She was also diagnosed with an early staged breast cancer and she was a very private person. She really didn't want to tell anyone, but she had adult children and she had siblings and she struggled with this decision. And she wasn't close. She was close to her children, but not to the other family members. And the struggle was she definitely knew that she had to tell her children at some point because she wanted them to be able to get testing and figure out what their risk was. But she really didn't want to tell her other family members that she, had a cancer diagnosis, and she was worried about how they were going to share this information. They weren't close. And so she really struggled with what she was going to do. And sometimes we don't have an immediate answer too. We can just work on a piece of that. Like, okay, let's just talk about your children. They're the closest to you. Let's deal with them first, and then we'll move to the next group and see what you want to do. So really a challenge for that particular patient. And another patient that I saw recently, this was really more about sort of her risk perception and her ability to cope. She did not have a cancer diagnosis, but she was positive for BRCA. I don't remember which one. But she wanted to do a prophylactic mastectomy, right? And so, the surgeons will send patients to me to see before they allow the surgery, just to see where people stand. And sometimes you might think, well, if they have severe mental illness or psychological disorders, maybe you wouldn't agree that surgery would be a good idea. But in this case, right, the severe psychological comorbidity, right, would have been so extremely difficult for her to undergo the surveillance procedures of having to go into mammos or MRIs and do this, frequently, that she did not think she could cope with that. And so I supported her in this. I really think that the distress and inability to cope with those surveillance would have been greater than dealing with a prophylactic mastectomy, because she actually had a plan for everything. She had a plan for pain, body image changes. She had a plan for all these things, and she felt more confident in dealing with that than she could to walk into a center where she had to sit into a machine and get a test result. So, couple examples there. Okay, so what do you do? How do I help people cope with a variety of these different issues that they're dealing with? Well, number one, what I want people to understand is that distress is a normal reaction to a stressful situation, such as a cancer diagnosis, positive genetic predisposition, indeterminate a result, or even a negative, right, if they have that survival skit. So we want to establish this, there's some sense of normal reaction, right? Because I think the way that we structure distress screening is we often think about elevated distress as maladaptive, right? Like we don't want people to be distressed. We want their distress to be below 4, right? If we use that 0 to 10 scale, we want it to be lower. But is that a faulty assumption that low distress means somebody is not adapting well or coping well? Maybe it's not really about that. It may be that no matter what your level of distress is, you find a way to cope with it, and that is what's adaptive, and not for us to try to prevent distress. So I think the goals that we really have for people is learning emotion regulation, right? So understanding their emotions, recognizing them, learning how to manage them, and also developing or enhancing this idea of psychological flexibility. This is kind of a new concept that's come about with what we call these third wave cognitive behavioral therapies, like acceptance and commitment therapy, is that we want to accept living with an experience of difficult emotions and still being able to act and live and follow our other goals. And so the idea then is that if you're doing emotion regulation and you're being flexible, the reduction in distress kind of follows along naturally with these other tasks. And so it's kind of just a different way of looking at it, because I know in the beginning, right, I'm cognitive behavioral trained. In the beginning, it's like, okay, what's your thought? Let's change that thought, and then you will feel less distressed. And so we're learning to do that in a different way now. This slide here, this model for step supportive care, I only put it up here as an example. This is not based in working with patients with inherited, hereditary cancer, but it was suggested for use with people with cancer in general. But I think the point I want to make is that everybody needs information and support. Everybody, it doesn't matter who you are. And the majority might need, some additional encouragement, right? Having peers or group support, right? We want to be able to connect with other people like we're doing now, other people that have the same issue, the same field. I think that's very helpful. And then there's going to be smaller percentage of patients that we classify as, maladaptive, where you need to be able to recognize who those individuals are, maybe some of those and that with that, those risk factors, or who's, you can see that they're not functioning well, that you can get them connected with this level of support. Okay, so typo on my slide here. So let me just, I'll tell you what it is. Problem focused, attempt to remove or reduce the cause of the stressor, right? This is very practical. We're going to solve problems. We might manage our time better. It's instrumental. Emotion focused it should be attempts to reduce that emotional distress, right? You're not removing the stressor, you're just you're changing your emotional response to that. So problem focus, right? What's the problem with problem focused? Depends on how you identify your problem. If the problem is like, I have a problem in how I'm going to communicate these test results, okay, we can solve how to do that, when to do that. If the problem is having the genetic predisposition, you can see the challenge here. If a person says to themselves, well, the only way that I can deal with this is if I just don't have this problem anymore. And we can't remove, right, hereditary predisposition. And sometimes we can't even, remove the cancer. So we have to shift the problem. So emotion focused, I'll show you on the next slide. It's going to show you a variety of different strategies that help people to reduce that emotion. And then meaning focus. So this is really in line with that idea of third wave CBT, where you're going to call on your beliefs and values and goals, and that's going to help you cope, right? So it's, whatever health issue you're dealing with, whatever problems come along with having inherited predisposition, that does not become the center of your life. You still have other values, right? There might still be work, family, volunteer, any other goals that help you find meaning. Sometimes you have to redevelop this, right? If your idea of family, you're going to have a big family and all these kids, and now suddenly you know, fertility is not an option because, you know, you've had some kind of risk reducing surgery, no more ovaries, that sort of thing, then you're going to have to sort of redevelop or redefine what family means to you. So that is an important strategy for coping. So here's emotion focused copings. Really? Okay, I guess I have them on to fly in there. So these are all, we should all recognize these, right? We all do some of them that help us kind of deal with our emotional response to difficult situations, distraction, prayer, you know, meditation, some things we do on our own, some that are often taught, you know, within therapy sessions, like how do you reframe your thoughts? I will point out, right, that not all of these are recommended strategies. So you probably see a few on there that you wouldn't recommend that you do, right? And can be problematic, right? So this idea, sort of wishful thinking, right? You know, you get that result and you just, you know what, these are the lost to follow-up patients, right? Like I can't deal with it. I'm just gonna put it aside and then I'm just gonna go on with life how I normally do it. And I'm not gonna engage in any, you know, follow up with, you know, do my follow-up appointments, et cetera, right? For me, those are the patients that I see them once or twice and then they kind of drop out of treatment, unfortunately. So I don't recommend that, right? We want to help people move past that. Denial might be okay for a short time, but again, if I see people that are not engaging in the behaviors that they need to, then it becomes problematic. Mindfulness meditation. So I wanted to define this because this has really exploded in recent years as a coping strategy. We're starting to see a lot of the psychological therapies, including training in mindfulness, right? And it's this idea of learning to be living in the present moment. So what does it mean in the present moment? We can accept that we have sort of positive and negative experiences, thoughts and sensations. We can recognize they're there, but we don't latch onto them and continue to focus on them, right? We just can kind of let them go and just be present, right? So we can see this being helpful, right? If people are worrying so much about the future, thinking about what's going to happen, they're not able to live and focus on what's going on right now. So we want to teach them to be able to do that. So I want to put a little plug for providers, right? All of you are providers that you can face challenges to your emotional well-being too, right? And it can be from, you know, the work that you do with patients and seeing patients that are suffering, you know, and struggling with how to cope, or just the kind of workload that you're dealing with. And so the strategies that I mentioned can be helpful for you as well. So I did want to include some references in case you wanted to go back and read some more information. And I wanted to mention one more thing about mindfulness, and this that there's a study on using mindfulness with genetic counselors, and by Silver and colleagues, they found that if the counselors were practicing mindfulness, they were more likely to have more empathy and work engagement and less burnout and compassion fatigue. So it might be something that you want to incorporate for yourselves as well. So
thank you, Laura. You know what we'll do is we will send out these references if anyone wants them. So just contact ICARE. I think we will go on to our case because I really want to get into the discussion with both Marleah and Kathy. And we as a panel can kind of, these are going to be real. I know Lora had given us some great examples of her work over the course of seeing patients, but these will give you kind of real life examples of what actually happens and how people face this, the option for testing, and then once testing is done, what happens afterwards. So moving on. I'll present both cases. So the first case, usually we don't do this, so this is a little different, but we're identifying who these cases are, like the proben for each of the cases. So case one is Marleah's personal and family history. And I already introduced Marleah earlier. So here's the history. Mom was diagnosed with breast cancer at the age of 38. Sister within 2 years was also diagnosed with breast cancer at age 38. Maternal grandfather's mother died from breast cancer at a very early age, which developed during pregnancy. But mom was not tested until 2010, at which time the BRCA2 mutation was identified. Her younger sister was almost simultaneously tested, so tested thereafter quickly. Also tested positive for the BRCA2 mutation. As a side note, older sister had a total abdominal hysterectomy, bilateral oophorectomy, a salpingo oophorectomy at age 50, but didn't test until age 61. So unaffected with breast cancer. She also has the BRCA2 mutation. Going back to Marleah, Marleah tested in 2013, and her current cancer risk management regimen includes the breast cancer surveillance, both through yearly mammograms and breast MRIs. So you see here the family history. Here's Marleah, Marleah's mom. Both sisters are positive. And one of the sisters, so her mom's younger sister, has also been diagnosed with melanoma a few years ago, in addition to the breast cancer at an early age. And then the grandmother, father's mother, this is not correct on the pedigree, was actually breast cancer. And again, I think these are the kinds of things that come up in families, but I know Marleah has looked at the death certificate and confirmed it was actually breast cancer, not ovarian cancer. And here is the genetic test result. We had actually run a CAN risk for Marleah. And again, CAN risk, as many of you know, is a way of incorporating the mutation, but in addition to that, the other risk factors, whether it's breast density, hormonal risk factors, pregnancy history, et cetera, family history, et cetera. So what we found through that is, again, we've talked about this before, 5 and 10-year risks are really the most important. And again, you see here, the next 5 years, 5.4%, 10 years, 13.9%, but over 80% between now and age 80. So again, very high risk. And then ovarian cancer risk, what tends to happen with CAN risk is some of the factors that raise the risk for breast cancer are actually protective for ovarian cancer. So you see lifetime risk of ovarian cancer is in the range of, a little less than 6%. Again, it's always important when we give these CAN risk estimates to know that, we're not that precise where we can give an exact number, right? Even though that's what we're doing, but it's really a range. So it kind of gives you an idea of what your risk is, but I wouldn't take it as, okay, that is the exact risk. So there were a number of things that we wanted to kind of briefly touch upon, like the timing of testing, as well as some factors associated with cancer risk management that Marleah has faced. But I'm going to turn it over to Marleah to kind of talk about her experience, and then we'll open it up for a panel.
Thank you, Tuya. So you've heard a little bit about the biomedical perspective of my story. So just to briefly kind of touch on some of the connecting the psychosocial and the medical perspective, given our topic today. So you've heard my mother was diagnosed at 38. I was 8 at the time, and I have a younger brother. He was 4. And so it really felt like for a few years, I grew up in hospitals. And because of those experiences from a very young age, I kind of assumed I would get cancer. That's just what happened to the women in our family. In the midst of their careers and families and hobbies, they battled breast cancer. And so you can see some of those distress risk factors that Dr. Thompson was talking about a few minutes ago. But at the same time, those early childhood experiences really propelled my desire to get my PhD in healthcare communication. And now I conduct research trying to understand and improve communication about genetic risk between family members, patients, and clinicians. In terms of timing of genetic testing, I'll just talk about that very briefly. So when I was working on my PhD, it was 2012. I decided to see a genetic counselor. It was about 2 years after my mom had tested positive and my aunt. My husband and I and my mother actually went to the genetic counseling appointment. It was very helpful. I felt like I had all the information I needed. I had a good understanding of what would happen if I tested positive. But I decided not to undergo genetic testing at the time. And in fact, they had given me a saliva test kit, and I took it back home with me and I put it in my safe. And it sat in my safe for a year. And I share that with you because I just wasn't ready yet. Even though I had expected, oh, I might be diagnosed with breast cancer someday. I was doing this work in my dissertation. I just wasn't ready. And I knew that if I tested positive, that it was going to change my life. So I wanted to make sure I was absolutely ready. So I ended up testing positive then in 2013, over a year later. In terms of cancer risk management, just a couple points I'll make. So I have been undergoing increased surveillance for over a decade now, tested positive at 25. Now I'm 35. And it has been a successful regimen. I have found it to be very helpful in general. I know the goal. It's looking to catch the cancer early. At the same time, however, it's created a lot of distress in the family because my parents are very clear that cancer ruined their life, and they really don't want me to be diagnosed with cancer. And so in addition to managing my own emotions and cancer risk management, I also have to manage their emotions. And I'll share just very briefly, I actually had a text conversation with my dad last week because one of our good family friends was diagnosed with breast cancer, and she has 2 very young children. Mine are 7 and 3. And so he and I spent a good half an hour going back and forth about why haven't you scheduled your prophylactic bilateral mastectomy yet? And so having those conversations with my family has been a part of my cancer risk management too. The other distressful moment, I think, in thinking about reflecting on Dr. Thompson's conversation about coping with distress, one moment that was really distressful was after my son was born. So it would have been my first MRI after my son was born. It was about a year and a half, I believe, because I was breastfeeding. Well, I had been pregnant and breastfeeding, so it had been a year and a half since I had had my last breast MRI, to be clear. And so I was already nervous, and I was already starting to, I'd been doing this for a while. I knew different strategies that would be helpful, before the breast MRI. I knew the day and the night was going to be hard. So I reminded my husband, I did some meditation. I was trying to identify different emotional distress feelings, right? Was I more nervous, or was I over here? Was I really anxious? Was I depressed? Was I hopeless? What was happening? I also plan to treat myself after a cancer risk management screening. So I can't remember if it was a mocha at Starbucks or lunch with a friend, but I usually do something like that, a massage, take a hike, things that bring me joy. And unfortunately, the radiologist found something suspicious. I had a biopsy, and waiting for those test results was terrible. Now, I was not diagnosed with cancer, but in that moment, I realized that my uncertainty about am I going to be diagnosed with cancer someday, and the distress that was associated with that was really never going to go away. And so it was at that point that I started to realize and think about no amount of information is ever going to completely reduce my uncertainty. No amount of coping mechanisms is ever going to make me feel completely better. Friends and families who might text me or send encouragement, it would help, but it would never completely go away. And I think by just accepting that, embracing that uncertainty, that as I move along this journey, that ended up really helping me. So those are a few things that have influenced that. Now, I'm done with family planning now. So I am starting to have conversations about undergoing surgeries. And I'm happy to talk about some other things, but given time, I think too, I will pause here and let you go to the next case.
Yeah, so let me do that, because I want to also hear from Kathy, but that was so enlightening. Thank you so much, Marleah. So let's go on to Kathy's, and then we will have the panel discussion at the end. Because again, I think a lot of the themes, what's interesting is the theory that Lora kind of discussed at the beginning is what basically Marleah has used, like in terms of implementation and some of the family factors and other things that have influenced, you know, what she's having to deal with, how she's coping, kind of came through with the theory that Lora enlightened us with. So again, I think Kathy's case, again, you will see some common themes as well. So, you know, I already introduced Kathy Baker, founder of My Faulty Gene. So in terms of history, Kathy's sister was diagnosed with breast cancer at age 32 when Kathy was 30. And then the other family history was maternal grandfather had died of prostate cancer at age 65, and his mother had died of pancreatic cancer. A couple of years later, Kathy had a mammogram. I think she was in law school. It was a mobile bus, so it was convenient. It was normal. And she really had no plans to repeat it until age 50. And then at age 42, she was diagnosed with stage 2B breast cancer, treated with lumpectomy, and she was offered genetic testing at the time, but declined it. And what was interesting here is with her ongoing visits with her oncologist continuously brought it up and had the discussion. But again, Kathy declined the testing at the time. Finally, at age 51, both Kathy and her sister had testing after becoming aware of the Metcalfe story. And I'll let Kathy describe that, but it's a very interesting story where our other panelist, Kelly Metcalfe, had just published a study looking at these factors that may influence people with hereditary cancer predisposition to get testing. So regardless, she was found to have a BRCA1 mutation, had risk-reducing surgeries, and on her risk-reducing salpingo-oophorectomy, early-stage ovarian cancer was detected. And so looking at the family history, you can see here, I've already described it, but you see the multi-generational cancer history. So I'm going to turn it over to you, Kathy, to kind of give your perspective and add some of the other things that I didn't cover.
Okay, great. Well, mine is an odd case because my testing being 9 years after my breast cancer diagnosis, and that's not the fault of my wonderful med onc because he was great. He Harvard grad, very intelligent, knew that there was a need, but he was not a genetic counselor. And our community hospital had no genetic counselors to offer back in 2000. There was just no one there doing that. So, you know, and I wanted cancer in my rearview mirror. I didn't want to think about it. I wanted it behind me. And we had many things. My husband had lost his mom to cancer when he was 15. So he had things he dealt with. I had children who were experiencing emotional distress because of my cancer, you know, seeing mom without hair, seeing her, all the things. It was difficult on my family. So I just wanted it behind me. And I thought I was one and done. So when I was offered testing, I just, you know, I was not given a reason to understand why I needed to go forward. Fast forward, the mention of the Metcalfe study, Dr. Metcalfe, a Myriad rep, was very tenacious, getting some office times with the med-onc, with my oncologist. He waited and waited and waited, and finally was presented with some time to talk to him. And he shared this study of 491 women with a known BRCA mutation who had had breast cancer, early stage, stage 1 or 2, basically. And what was the likelihood that they would go on to get ovarian cancer? And it was with over a lifetime, looking at the lifetime risk, I believe with a BRCA1, it was 1 in 3, and with BRCA2, it was 1 in 7. I may be wrong, but I believe that's correct. Knowing that, when I went to my next appointment, I had something new to rely on. I had some information, and it's something that changed my life. It saved my life, because knowing that, I'm very pragmatic. Give me information, something that I can deal with, that I can hang my hat on, that I know I need to do going forward. There was no decision. Of course, I'll do genetic testing at that point. BRCA1 positive, went forward with the testing. And I knew that the next step then was going to be to have the risk reducing surgeries, because I still had breast tissue. I'd had lumpectomy. I still had my ovaries. My sister had already had double mastectomy, had also had total hysterectomy with bilateral salpingo-oophorectomy. So she was not at risk. I was the one at risk, and I went forward. We waited until Mom died of cancer 6 months later, and then I found 3 surgeons who were willing to work together, went forward with my risk-reducing surgeries, all piggybacked together over 10 hours, and they discovered ovarian cancer during that, early ovarian cancer. But I am not a patient who would have been presenting with the vague symptoms of ovarian cancer. Everyone that knows me agrees that I would have been late stage when I presented. So I credit my shero there, Dr. Metcalfe, and my hero from Myriad, Bill Hickox, for saving my life, and my oncologist, Dr. Frank Ward. I mean, it was a team effort, but it made me go forward. But I was not in distress in learning that I had a BRCA mutation. It gave me the knowledge and the power. I felt like I was empowered by learning it. And I immediately began to try to impact my family. I would say, within a year, all of my first degree relatives had been tested, and most of my second degree relatives, because I understood the importance. And I was able to and plus my story, with them learning that it had been life-saving for me, it was very impactful for our family. And all but 2 of my second degree relatives have had genetic testing, and they have not been afraid to have that. I have one uncle who has refused adamantly to have testing, and that's his choice. And then I have a nephew who's waiting until he's 30. But I feel like we've had a lot of success there. But no one is fearful of it in our family. We understand how we can be empowered by it. So to me, from a psychosocial standpoint, the fact that I now face 2 cancers, I still have certain cancers I'm at risk for. So I still do have those issues that come up. I do follow-ups. If I have, I'm not going to say I live in fear, but I live with an understanding of what could be because of my knowledge that I gained. So I'm able to take that. And when I started having problems in my gut this year, I'm like, okay, first thought was, okay, could I have primary peritoneal cancer? That's one of my risks, And after lots of workups and actually my gynecologist doing a surgery, a laparoscopy to see what was going on, it was a lot of adhesions and things. It was not cancer. But you know what? I have that knowledge, was able to go forward, and I have relief knowing that. And so I just try to take all of the information I get, go forward, and know that I'm empowered because of my knowledge.
Thank you, Kathy. Kelly, I was just wondering if you have any comments, because you've done research in this area for, I don't know, last few decades.
Yeah, no, and I first want to thank both of our speakers for sharing your stories. And I think what's always you know, it reminds us as scientists and clinicians about why we do what we do. So thank you for sharing your stories. But I also think what it highlighted today is we have two people here who have a very similar, you know, you both have a BRCA1 or BRCA2 mutation, and yet you've taken that information and dealt with it differently. And so I think it's really important to remember that there's not a one size fits all in this area, right? Everybody's going to deal with it a little bit differently. But we need to be with you in supporting your journey and using the evidence that we have on the effectiveness to ensure that, one, you reduce your risk of getting cancer, and that might be either way, or for the breast cancer, thinking about screening and detecting those cancers earlier. So our ultimate goal is to do genetic testing to reduce the risk of someone either getting cancer or dying of cancer. So our goal in managing patients after they've been identified with the mutation is really that goal together. You know, and supporting all of the psychosocial issues that go along with that, because everybody does experience this so differently.
Yeah, no, completely agree.
Yeah.
And you know, what struck me with Kathy's story as well is she had an oncologist that was vested in getting her tested, yet, you know, access to a genetic counselor could potentially have been helpful just to be able to explain, like, these are complex sorts of messages that we're giving. And even with Debbie and my research, what we found is, like, even if we explain it to a patient, right, like the family communication piece, it's not always easy for the patient to then highlight it for their family members. I mean, Kathy has obviously had a lot of success, but it's not always that way. So having tools at our disposition to be able to help with the family communication. And again, I'm going to give a shout out to Brian Schertz, who's the founder of Connect My Variant, that some of us work with. Brian just joined Vanderbilt. But again, there are tools out there that I think are really exciting that could move the needle with even the cascade testing. And I know Kathy didn't say anything, but she has also, through her efforts, built tremendous resources with patient stories and like videos that are very, very professionally developed. I was going to ask Lora about your perspectives, because you know what you talked about kind of came out in what both Marleah and Kathy said.
Right. Again, I also appreciated both your stories and highlighting some different aspects of what I talked about. Marleah, you had knowledge from early on. You actually gravitated towards the field. You probably had lots of knowledge and knew kind of
Yes.
what to expect. And so your story really focusing on kind of acceptance of your experience and understanding and how, highlighting even the distress of other family members can fuel your own challenges, but you've found different ways to cope and to really understand your emotions. So that's I'm glad you were able to do that. And Kathy, I think you said you didn't have the information, right? You were from the other side, was maybe because there wasn't a genetic counselor and it just wasn't available. But information is powerful, but you really focused on sort of understanding your own coping appraisal, right? It seemed to me you had confidence in yourself and your abilities, what you could do with the information. You used the word empowered, and you had confidence in what was available in your medical community, in your physicians or oncologists, the science and what's out there and available, and even if another cancer comes, I'm guessing you have people you can go to that you feel good with working with. So I really think, yes, your story is sort of highlighted two different areas, but I appreciated hearing them and seeing, kind of my sort of knowledge reflected in what you've dealt with.
Yeah, that was actually really neat the way that came together. Debbie, do you have any thoughts? I know that you've also been working in this area, some of which together, some of which you've done on your own, but just give us your perspectives. You're muted.
I'm not muted.
No,
Can
no,
you-
now you're good. Now you're good.
All right, so I just want to put these stories into a little bit of context because they were fantastic stories. They both come from very well-educated white women, though, and I do think that there might be some additional challenges with other individuals that, and their voices are not heard nearly as much. So not to downplay your stories at all, but the fact that it can be so hard, even with people who have some of those privileges in terms of, having access to information or to doctors or to resources. It's challenging for everyone. And I can't imagine some of the challenges for some of the other people out there who we don't hear their stories enough.
Yeah, that's a great point. And I know, so Kelly is obviously based in Canada, which is a totally different health system. But even in Canada, where there is coverage based on certain criteria. So we've taken coverage, we've taken management off of the table, yet everyone's still not getting identified. Everyone's still not getting the care that they should be getting. And part of Kelly's research has been because she's seen it. People who had a BRCA mutation end up with ovarian cancer because they were lost to follow-up and, they got stage
And I
3.
think we're going to continue to see this too, Dr. Powell, because thinking about how genetic testing is exploding, really. I mean, it's becoming so much more, that the uptake is so much higher and it's being integrated into clinical care, especially as we have some new therapeutics and thinking about testing at the time of diagnosis, because PARP inhibitors can be delivered. But then let's think about that trickle-down effect. How are we going to get those family members? Because they're the ones at the highest risk of anybody out there walking around. So, I think, Kathy, you highlighting the fact that you didn't have access to a genetic counselor, I think that is, happening more than we think it's probably happening now. So how do we think about supporting people when they're making the decision to have genetic counseling or genetic testing and following them to help them make decisions to ensure that we're taking care of their health and preventing these cancers from happening? So I think we still have a lot to do. And I think, Tuya's ICARE registry is really helping us to be able to look at some of those questions and develop new models of care to support people as we're going forward.
Yeah, and you're right, Kelly. The testing is exploding. So at the end of the day, and we always hear about population screening efforts, and we're getting to a cost point where if you do the analysis, maybe it is cost effective. However, we need to have the decision support piece in place, right? And testing is not going to change outcomes, it's what you do about it.
Exactly.
We like, our problem is not testing nowadays. I think it's making sure we have the downstream, because again, at the end of the day, when people know about it, they don't share it, and then their family member ends up getting metastatic cancer. I can't imagine that feels good, right? Like, so again, I think that I agree with you. I think there's a lot to do. I think leveraging technology, we'll have to leverage technology because we'll have to do it at scale. But like Debbie mentioned, there are disparities. So giving people what they need in order to be able to either understand what's going on and then act. So I think all of us need to be moving that forward. I know we're at time, so I will close out this session, but I really wanted to give a big thank you to Lora, Marleah, Kathy, for the presentation and sharing your stories. And then Kelly and Debbie, thank you so much for being our panelists and again, sharing your valuable perspectives. We have some upcoming case conferences scheduled for next year, but for the next couple, I have Mark Tishkowitz as our guest expert talking about ATM, and we'll kind of go through our new publication, but also present some interesting ATM cases. So if anyone is interested in submitting, please, feel free to do that. And then February, we have Fergus Couch as our guest expert. And for those of you who don't know Fergus, most of you probably do, the focus will be on BRCA2 missense variants, including some of the work on hypomorphic variants. So again, more to come on that, but please submit cases that might be of interest. And again, this kind of goes through our upcoming case conferences. We have quite a great lineup, in my opinion. So again, we just have a few slots to fill. So with that, again, thank you so much to our experts and our panelists, and we will see you next time. Thanks, everyone.